All right, good afternoon. Welcome to Envision New Mexico. This is Kirsten Bennett. I'm the Telehealth Program Manager, and I'm going to function as your facilitator today for the second in our series of the Pediatric X Talks modeled on TEDx. And I'm going to turn it over to Kevin Whirling, who is our IT specialist here. He's going to go through a little bit of housekeeping. And then Dr. Mason, I see that you're on. I will call on you to give a little bit of background about the Ped Society's goals for this series, and then I'll turn it over to Jen Robinson, who's going to be our presenter today.
So good afternoon, Kevin Whirling here, Systems Analyst at Envision New Mexico, and wanted to remind you we are recording the session today, so please don't include any confidential patient health information during the session. On screen is how to connect to audio using your telephone. If you can't use your computer or computer mic and speakers, or you would prefer to use your telephone, then use the information here. Press *6 to mute and unmute yourself. Please don't place us on hold, or we will hear your hold music, and I can mute you if needed. And cameras are enabled, so we'd love to have you on camera. I see Melissa Mason is attempting to do so right now. We can see you, but you're a blank screen at the moment. Might be a bandwidth issue. Hopefully that'll clear up. So click Start My Webcam and then start sharing once you're done previewing. On screen now is our disclosure and accreditation statements. And we would say if we had anything to disclose at this point. We don't. Molina and Blue Cross Blue Shield Centennial Care do offer providers reimbursement for bringing your patient consultations to us, to any of our sessions that are a teleecho session. So please contact us for more information on that. Michelle Widener is the expert, and I can also act as a backup. So now's your opportunity for roll call. If you're out there, please let us know that who you are and where you're from, please. And *6 if you're.
Hello?
Welcome.
Hello?
So please say your name and where your practice is situated.
My name's John. I'm a nurse at First Choice.
Welcome, John.
Hello?
Who else do we have?
Hi, this is Lori Ann Romero. I'm a family nurse practitioner.
Where do you work, Lori?
I work for Albuquerque Public Schools and for Catapult Health.
Oh, great.
Anyone else?
And if you're not able to speak, you are able to use the chat box as well to make sure that you can get credit for your CMEs.
Sounds great. Thanks.
So to receive CMEs for the session, we either need to have you announce your name over your audio or in the chat box so we know you're there. So at this point, Melissa, if you can hear us, Dr. Mason, please unmute yourself and tell us a little bit about the PEDx series so that participants have the context for our talk today and sort of where we're going over the next few months with this series. Or not. So we'll check in with Dr. Mason toward the end. So I'm going to turn it over to Jen Robinson, and I'll let you introduce yourself too, however you like to be remembered.
Okay. I'm Jen Robinson. I'm a women's health nurse practitioner and I'm a nurse midwife at the UNM Young Women's Clinic. So we are an adolescent reproductive health clinic that's co-located here in Albuquerque with the Center for Reproductive Health. And I'll talk a little bit more about my clinic as we continue through the presentation. And that would be right now. Hi, Dr. Mason. This is one of our promotional flyers for the Young Women's Clinic. You can see some of the services that we provide at our clinic, and that age range that's listed there is flexible. It does say 14 to 21. I do see adult women, and we also do see women under the age of 14. Primarily providing long-acting reversible contraception, also offering the other services that are listed there, and prenatal care for adolescents as well. And you can see on the little map there, we're located near the airport, across the street from the Waffle House on Yale. And these are the objectives for today's talk. Mostly we'll be talking about strategies and principles for how to talk with adolescents about contraceptive options. Before we get started with the meat of that, I wanted to talk about what is long-acting reversible contraception and how it is safe and effective in the first-line option for adolescents and women who have never had babies before. So once I talk about the content of the long-acting reversible contraception, then I'll move into talking about different steps and principles that the CDC recommends using for contraceptive counseling. And this is a small group today. If anyone wants to interrupt me with questions on the phone or in the text box, please feel free to do so. And I'll try to also allow some time at the end for questions. It's really important to know that, especially over the last few years, there have been a lot of professional organizations coming out and voicing their support for long-acting reversible contraceptive methods, which I'll now refer to as LARC. So what LARC options are IUDs. There are several options that we'll talk about, and also the contraceptive implant that's subdermal and placed in the arm. So in October of 2012, the American College of OBGYNs made a statement promoting these methods as effective first-line options for adolescents. And then in October of 2014, the American Academy of Pediatrics voiced their support, and you can see that direct quote up there from their statement. Also, the CDC, Title X, many other professional organizations support the use of these methods in adolescents as safe and the most effective. So as a little intro to LARC methods, I wanted to talk about a large project that was done in St. Louis with adolescents and with adult women by providing evidence-based contraceptive counseling and reducing barriers to access to LARC methods. They measured satisfaction and continuation rates across age groups, and also wanted to look at the effects of providing these LARC options along with other contraceptive options on pregnancy and abortion rates. And this is a great and very beautiful website that the Choice Project has. There have been many academic publications that came out of this project, and this Choice Project website is a good place to go to that has the links to all of the academic articles. So it's important to note that it's not just the professional organizations that think that these methods, these LARC methods, are great for adolescents. Adolescents also like them. So when they were given the options in the way that I'm going to present today, for all of the options for contraception, they overwhelmingly chose the LARC methods. And you can see the research that supports that with that published article that's cited down there. It's also important to mention that some of this information I got from the Physicians for Reproductive Health website. They're a great organization that provides a lot of evidence-based information and presentations related to reproductive health topics. And there are many presentations that they have on their website that can be downloaded for free that are specific to adolescents. So whenever you see the Physicians for Reproductive Health logo in the corner, that information came from their organization as well. Important to note that even when all the barriers have been removed to access to care, so removing the barrier of cost, and providing adolescents with all the information that they need, they still had access to any of the methods that they had initiated. At the year mark after initiating the method, 86% had continued with the long-acting methods, whereas the non-long-acting methods, which are the depot shot, the oral contraceptive pill, the vaginal ring, and the patch, were only continued at 55%. So a lot more women will continue to use the methods once they're initiated as well. And you can read on the slide that there was a huge impact and decrease on the teen pregnancy rate. Also, the abortion rate and the birth to teen rate were decreased when adolescents have access to the long-acting reversible contraceptive options. And this is comparing the choice data, again, from that project that was done in St. Louis with national data. So I'm just going to briefly run through some basics on what the LARC methods are before we get to talking about how to talk about these methods with adolescents. There are currently 3 hormone IUDs on the market. The Mirena is the most well-known. It is approved by the FDA for 5 years of use. The Loletta is newer on the market, currently only approved for 3 years of use. They're very, very similar in the amount of hormone that they have and in their side effect profile. And you can see exactly where the IUD rests inside the uterus. There are a lot of great visual aids that I'll talk about a little bit later in the presentation to help facilitate conversations about IUDs with your patients. Important to know that with the hormone IUDs, especially the Mirena and the Loletta, amenorrhea or unpredictable infrequent spotting are the most common changes that people notice after initiating these methods. The Loletta has been proposed as an option for lower income folks. If people have nonprofit pricing, it's only $50 to purchase the IUD for the clinic. So that's kind of their niche in the market. The Skyla, you can see the size comparison. The Skyla on the slide is the pink and the Mirena is the blue. So the Skyla is marketed towards women who have never had babies before. And it is slightly smaller. It does have a much lower hormone amount, which means that the side effect profile looks different. There's much more irregular bleeding than with the Mirena. And that little copper guy on the side is what I'll talk about next, which is the Paragraph IUD. I like this slide so you can see the size comparison. The Skyla is only approved for 3 years of use. Really important to know that any of these IUDs are appropriate and safe to use in women who have never had babies. It's just that the Skyla is particularly marketing that towards that group. Just briefly want to mention the mechanism of action for all of the hormone IUDs is the same as any other hormone contraception. So there are a lot of myths and rumors. Some of them are incredibly creative that I've heard over the years of talking about IUDs. Really important to know that the primary mechanism of action is the thickening of the cervical mucus to even prevent sperm from even getting up there. You can see the other mechanisms mentioned on the slide, but the most important thing to remember about IUDs is they're not causing abortions, they're preventing fertilization. The copper IUD is hormone-free. It's FDA approved for 10 years of use. What's different about the copper IUD is that it is very, very effective as emergency contraception if placed within 5 days of unprotected sex. The mechanism of action for the copper IUD is changing the way that the sperm are formed to prevent fertilization that way. This is a great option for women who don't want to use hormones, and they would still get the same regularity of periods with this IUD. The main side effect is they could be crampier, last longer, and be heavier in flow. And this woman looks much more relaxed than most of my patients when they come in to get their implant placed, even though it is not a painful procedure. So you can see the instrument that we use to place the implant on this slide, and then also the actual size of the implant, which is about the size of a matchstick. This is another progesterone-only method. All of the hormone IUDs that I talked about are also progesterone-only. This is FDA approved for 3 years of use. Again, the primary mechanism of action is the hormone mechanism of action. It says inhibits ovulation up there, also thickening the cervical mucus. And then we'll talk a little bit later about the changes in bleeding patterns. With the next one on implant, it's important to know that the bleeding pattern can be a little bit wilder than on the IUD. So more potential for frequent spotting or prolonged spotting and less likelihood of amenorrhea with this method. So for the rest of the presentation, I'll use these key principles from the CDC to kind of lay out how you can do your contraceptive counseling with patients. And I'll include a link for this document that I pulled this information from at the end of the presentation if you wanted more detail on any of these pieces of information. I always start out all of my visits with my adolescent patients by talking about confidentiality and consent in New Mexico. So it's important to know that we are very fortunate to be able to have confidential services provided to adolescents who are 13 and up. It gets a little confusing, and if anyone has any questions, we can talk about the details. I don't have my right-hand lady here who usually talks about confidentiality with me during these presentations. But I always reassure them that they can make these decisions on their own without needing to get parental permission, always encouraging involvement of parents if that feels safe for patients, but that doesn't always feel safe for people. So what is considered reproductive health care that can be confidential and that the adolescents can consent to is testing for sexually transmitted infections, contraceptive care, pregnancy testing, pregnancy options counseling, and pregnancy care, including abortion. And these are some really great websites where you can get more information and you can access some infographics like this to be able to have in your office. I have some cards in all of my exam rooms with this information, and it's a great jumping off point to talk about these laws with patients. That Guttmacher resources updated very frequently, and it has the most updated information about confidentiality and consent laws related to reproductive health care for adolescents and adults in all the states. So that's one of the ways that I establish rapport and trust with my patients is by letting them know what's confidential and what's not. An important caveat to that is to know that Medicaid in New Mexico will not send out an itemized estimation of benefits listing the services provided, but private insurance companies can. And so that's one of the limitations to actually providing confidential care in New Mexico related to reproductive health. And so I try my best to remember to mention that when I'm talking about confidentiality and consent with adolescents. A great way to start out is after you've established that information related to confidentiality and consent is asking patients what they're wanting to get out of the appointment and asking them if they have any questions right off the bat. And I can go into this information a little bit more. Sometimes it's nice to ease into talking about contraceptive options and sexual health by talking about a few other things first. And a lot of the PEDs folks that are attending today will be familiar with perhaps a student health questionnaire or other social history assessment tools that start out by just talking about the home environment, education, things like that, and then moving into the more invasive personal questions with time. Here are some benefits to personalizing contraceptive counseling. It just works better when we're kind of addressing each patient individually and assessing their needs and values throughout the contraceptive counseling visit. And this is a very brief summary of the most important pieces of health history to touch when you're doing contraceptive counseling. I put the contraceptive history piece in red because a lot of times adolescents will have had experiences and be pretty clear about what they're wanting to use for their methods. And it's important to ask what they liked about the methods they tried before, what they didn't like, and that can help you further personalize your presentation of the options. And also really important to talk about when the last time they had sex was. And I usually ask about when's the last time you had sex with a condom, when's the last time you had sex without a condom. And all of these pieces of the history are pretty well laid out in that CDC document that's cited at the bottom there. This has taken me by surprise so many times when adolescents are scheduled with me for contraceptive options counseling or contraceptive counseling, and they're coming in and I've had to backtrack when I didn't start with these questions about pregnancy because sometimes adolescents are ambivalent about becoming pregnant or even planning a pregnancy, but they didn't feel comfortable saying that when they were scheduling their appointment, or they've changed their mind since the time they scheduled their appointment. So these are some questions to get at assessing if someone is wanting to get pregnant maybe in a few months, in a few weeks, or if they're kind of not sure if they want to try to be pregnant right away. And I've given talks just about taking an adolescent sexual health history, so I won't go into that in great detail today. Again, that CDC document outlines more specific questions to ask to assess all of these aspects of someone's sexual health history. We've talked about the pregnancy history and plans a little bit. And if you wanted to see another presentation that I've given related to this topic, you can go to the Envision New Mexico website and look under the Adolescent Health Initiative. This is a very overwhelming slide. It's taken directly from the CDC document that I keep mentioning. Mostly I just wanted to keep this here for reference and just to point out that sometimes, especially if folks had had their training a long time ago, what people were learning was you needed to do a very comprehensive physical, you needed to do a PAP and a bimanual exam. And what we know now is it's not very often that we have to do those kinds of really comprehensive exams to initiate contraception. So there are a few exceptions to that. It's really good to get a blood pressure if you're going to start an estrogen-containing medication. Diaphragm and cervical cap hardly ever used, but you definitely need to do an exam for that to make sure it's fitted correctly, and definitely need to do a bimanual exam and a cervical inspection for IUD initiation. But for a lot of these other methods, that is not necessary. One thing that's not required but is helpful is to get a baseline weight and BMI for someone who's initiating contraception, because oftentimes, whether it is the fault of the contraceptive or not, adolescents will come in with the concern that their contraception could be leading to weight gain. So it's good to know where they started out if you're going to end up potentially having that conversation down the road. So again, just to reiterate, unless you're fitting someone for a diaphragm or cervical cap or doing an IUD, pelvic exams are not necessary for initiating contraception. Obviously, if someone has symptoms, you're going to want to do a pelvic exam, but it's not required on a healthy woman that's not symptomatic to start contraception. And then there's a list of all the other things we don't have to do unless it's indicated for some other reason. This is another overwhelming slide that's taken directly from that CDC document. Really important to just point out there is very little harm that we know of for initiating most contraceptive options if someone is actually pregnant. But it would be a great idea to figure out if someone's pregnant before we start them on contraception, because that changes the conversation. So I just wanted to point out this, if you strictly follow all of these guidelines, it makes it seem like you can only initiate contraception in like 1 week of the month for women. So if there are any doubts or questions, you can always call the Center for Reproductive Health. You can call me at the Young Women's Clinic and we can help talk you through this. Important to know, if someone's wanting to initiate contraception, you think they might be pregnant, the IUD is really the only method that could potentially interfere if you're in this kind of window of time with a pregnancy. And a lot of the methods that have progesterone, when I talk to someone about how we don't think that there's an impact of progesterone on a pregnancy, we talk about how most women that are pregnant produce progesterone, and progesterone is also used as a treatment to prevent pregnancy problems. So it is important to ask these questions, and definitely if you think someone could potentially be pregnant, to have them follow up in a few weeks for a pregnancy test. And Dr. Mason had asked me to talk about categories for eligibility and how to manage a few aspects of contraception, especially for women that have migraines. So I wanted to point out this kind of criteria grid, and just know that we'll be talking about this in the next slide. The category 1 is there's no restriction for using a given contraceptive method. Category 4 is there's an unacceptable health risk for giving that contraceptive method. And this again is from the CDC and the WHO. So this is cut out of a much larger grid that you can access by getting to that website there. And it shows, we're only talking about adolescents here, so if you're curious about the 35-year-old cutoff there, we can talk about that later. Really important to know that when you are talking to someone about initiating contraception, you have to assess if they have migraines, and if they do have migraines, figure out if they have aura or no aura. Because anyone of any age that has migraine with aura, it is not safe for them to use an estrogen-containing contraceptive. So that's the combined oral contraceptive pill, the vaginal ring, or the patch. And so automatically migraine with aura, no estrogen. You can see that the progesterone-containing options are safe for them. And the difference between, you can see there are 2 columns. The difference between that first column and the column that's next to it is if someone initiates a method, has a migraine, and then the migraine symptoms worsen when they're on that method, it changes them to a different risk category. So for example, if you started someone on Depo, which is listed on there as injection, and they had migraine with aura, if they changed to having worsening migraine symptoms, then they would move from category 2 to category 3, where you'd really have to deeply assess the risk-benefit ratio to see if you would want to continue that method for them. So that's how that chart reads. If someone has a migraine with an aura, needs no estrogen, progesterone only or non-hormone option. If someone has a migraine without an aura, you can start them on anything, but if their migraines get worse on that method, then you definitely want them to come back and talk to you. And if there are any further questions about that, I'm happy to talk about that. Dr. Mason also asked me to speak about using contraception to change menstrual patterns, especially for adolescents with disabilities. And so the document that I'm taking this information from is an ACOG committee opinion. Let me get to my little guide here to see if it's a committee opinion or a practice bulletin. But it is an ACOG document. It was a pretty short read, and I thought it was a really great resource, and I've included the full resource at the end of the presentation. It's a committee opinion. So first of all, really important to assess the reason for the request, because the reason for the request for change in the menstrual cycle for an adolescent with disabilities could mostly come from a caregiver, and it could be something that the adolescent might not want. So just like with any appointment, we want to really address the adolescent directly if they're able to communicate about this, rather than just talking to the caregiver or the family without involving them in their care. What ACOG recommends is using the least invasive and reversible option and the least harmful intervention. And so obviously this is individualizing the decision-making process depending on what's going on with each kid. ACOG mentions NSAIDs like ibuprofen as an option to reduce the amount of bleeding and also provide pain relief. So NSAIDs alone are an option if the concern is related to pain or heavy flow. Also continuously using oral contraceptives, which means taking the 3 weeks of the active combined oral contraceptive pill and discarding the placebo week and just continuing to take the hormone-containing pills. That can lead to about 50% of people taking pills that way having amenorrhea, but it can also increase the risk of unscheduled bleeding. So if the reason that someone is wanting to go on a method is to kind of predict when they're bleeding, that's not really the best option. It's also important to think about estrogen use. Again, that's the combined oral pill, the patch, and the ring. If you have a kid that's not very mobile, that's not a contraindication, but you always want to think about potential factors that could increase the risk of having a blood clot, because we know that estrogen can increase the risk of a blood clot. One thing I didn't mention is the whole reason that we're talking about migraines and estrogen being concerning is estrogen increases the risk of someone having a stroke if they have a migraine with aura. So sorry, I forgot to mention that before. If kids are interested in using Depo to potentially induce amenorrhea or decrease the amount of menstrual bleeding that they're having, important to consider how mobile they are again, and this is with Depo, it's for a different reason. It's because it can decrease their bone mineral density. So you want to think about things that they would be able to do to mitigate that effect, at least while they're on the Depo. And also important to think about the side effect of weight gain on Depo. So again, individualizing, looking at a risk-benefit ratio, kind of what's best for the situation that a kid is in. Mirena IUD is an off-label way to suppress menses. We do know that it can decrease the amount of menstrual bleeding by 70 to 80%. We also know that about 1 in 3, clinically I think I see more amenorrhea than what's documented in the literature, but it really just depends on what research you're reading. But the Mirena IUD can be a really great option for menstrual suppression. And important to know that Dr. Nancy Sakari, who's a pediatric and adolescent gynecologist who also sees patients at the UNM Young Women's Clinic, does put in Mirena IUDs for adolescents with disabilities under sedation. And they could come to our clinic to have an initial consult if that's something that your patients might be interested in. Ablation and hysterectomy are very rarely recommended in the adolescent population. Again, trying to just focus on the most reversible option. Is there a limit to how long you can have a patient on Depo to stop menses? There's not that I know of. I've heard a lot of patients coming in and saying, well, I've been on the Depo for a few years and I know about the effect on bone mineral density, and it's something that I'm wanting to get off because of that. So I've had patients coming in and saying that, but there's really no limit. What we do know, and correct me if you've heard something different, is that the bone mineral density is supposed to go back to what it was before after someone discontinues it.
Yeah, I don't have an answer for that, but certainly could look it up if people are interested.
Yeah, we can definitely get back on that. But I haven't heard about a limit. I think that there are a lot of myths out there about someone using any kind of hormone contraception for many years in a row. I've heard that as a concern from a lot of patients of different ages. I haven't seen anything for any of the methods related to like a maximum time that they can use it, as long as they're coming in every 3 months for their shot or getting their IUD replaced as often as it needs to. So from here on out, it's mostly just me sharing resources that I found to be helpful for my patients. This aspect of using decision aids that's mentioned in that CDC document is something that you can present to your patients if you wanted to give them some resources before they come in to read up on the different options. This is an excellent resource. This is bedsider.org, which is an evidence-based website that is also pretty to look at. And so this is one of the pages that patients can navigate to, and they can hover their cursor over any of these methods here, and it pops up with some specific information about the method, and they can click on it to obtain more information. They also have some like quizzes that patients can fill out to see like what kinds of side effects they would be comfortable with, or what kinds of changes in their periods they would be comfortable with, to help get an idea of what methods they might be interested in before they come to see you. Really important to interact with the patients and figure out what they already know, because a lot of times they come in being pretty sure, like my cousin got the implant, I want the implant. I always go through all of their options with them just so they can make a fully informed choice, but a lot of times they have a good idea of what they want. A lot of times they only know about one or two methods, so it's important to establish that level of understanding first. If you remember only one thing from today, I really want to emphasize the importance of using what's called a tiered approach to counseling. And what that means, this is a poster and also a tear-off sheet from bedsider.org. The tiered approach to contraceptive counseling means emphasizing the most effective methods first, and then moving down and talking about all of the methods, but in order of their effectiveness. And so I think that this is the prettiest example that I can give of tiered counseling and a visual aid that can help with that. The CDC, the World Health Organization, USAID all have a version of this kind of handout, but I think this is the nicest to look at. So just wanting to go through when you're doing the tiered counseling, the long-acting reversible methods like the implant and the IUDs first, and then moving to the other methods that are less effective. And I always talk about the reason that the LARC methods are most effective is because once they're in, you don't have to remember to do something on a regular basis. And with the other methods like the pill, you have to remember every day, the patch every week, and so on. Another thing that I really like about this visual aid is that it has the infographic on the side that shows the effectiveness. So always mentioning less than one woman out of 100 will get pregnant in a year of using the LARC methods, and then comparing that with the 6 to 9 out of 100 women on the second level. And then most adolescents that I talk to are really surprised that condoms are not very effective. And then we kind of talk about, why do you think that could be? And after we talk it through, it's kind of like, oh, okay, I guess you have to use it all the time for it to really work. So this is my very favorite visual aid. We have laminated copies in our exam rooms of this. And also all of these documents are available in Spanish on their website. Their entire website can be switched to Spanish as well. And I sort of alluded to this. Most adolescents and most people can understand effectiveness ratings when we're talking about it in terms of something out of 100 rather than talking about percentage points. I just wanted to share this other really nice handout. It again reflects that tiered counseling approach by having the most effective methods, the IUD and the implant up top. I think that this works better as a poster than a tear sheet, but it's just a different way to describe that information. And the other thing that the CDC really emphasizes is talking about risks and benefits, and that includes talking about non-contraceptive benefits. So finding out what the patient is looking for in their method and how comfortable they would be with menstrual changes, especially. The Mirena IUD is FDA approved to treat heavy menstrual bleeding, and what I had mentioned before when we were talking about providing this care to adolescents with disabilities is we can see a 70 to 80% reduction in the menstrual flow with the Mirena IUD. and the Mirena IUD can also help improve dysmenorrhea. The Nexplanon, some of the Nexplanon data suggests that Nexplanon can improve dysmenorrhea. However, we're not seeing it as much as with the oral contraceptive pill or the IUD. But if I have a sexually active adolescent coming in who's looking for contraception care and to prevent pregnancy and control of dysmenorrhea, I definitely would still encourage the LARC options more than the oral contraceptive pill. This is a list straight from ACOG about the non-contraceptive benefits of hormonal contraceptives, and obviously not everything in this list applies to every method of hormonal contraception, but I just wanted to leave that there for reference. This is another bedsider info sheet that I don't pull out that often. I find this to be the most helpful when I'm talking about risks related to IUDs because it really breaks it out nicely. It does have that infographic that shows the risks of having any of these or the actual incidence of these risks happening. And I'm not going to go through every risk of every method of contraception, but if anyone has any specific questions about risks, I can definitely talk about that. Basically, when I'm going through all the methods, I try to talk about how long they last, what you need to do on a regular basis, if anything, for them to work, and then the main side effects, the main risks, and the main contraceptive, non-contraceptive, and contraceptive benefits. So it's really important to be super transparent when talking about implementing any method, especially the IUD insertion and the implant insertion. So I just wanted to talk a little bit about how I prepare adolescents and patients in general for these procedures. So the IUD insertion is painful, and I don't lie about that. And I've gotten patients scheduled with me who didn't know it was going to be painful, and when we were doing the counseling piece before their IUD insertion, they've been so horrified that they might experience pain that they've had to reschedule the IUD insertion appointment so they could kind of sit with that information. So how I talk about it is I prepare them for the bimanual exam, talk about how put 2 fingers inside the vagina and feel the size and the position of the uterus first. If they've never had a speculum exam before, but they want an IUD, that is totally fine, and that is not a reason to avoid IUD as an option for them. I take out the smallest speculum that I have, and then I show them and I have them feel it, and we talk about what the speculum exam entails, and then talk about how it can feel like 3 giant period cramps to have the IUD go in. And then the cramps could last for a few hours, usually worse on the first day, and it could last for a few days or weeks after, but in the long run is a treatment for painful periods. So just important to be really real about that with patients. And if you have a patient and you're talking about contraceptive options and you want some more information about this, we have great nurses and great staff at the Young Women's Clinic and the Center for Reproductive Health, and we can always be a resource to help support you in these conversations with patients. I would say the number one fear of girls coming in to talk to me about contraception that are considering the implant is they're afraid it's going to hurt. And so I can really reassure them about the fact that this is not a painful procedure. And then I compare it with the IUD. I say, hey, look, I'm not going to lie to you. Getting the IUD put in the uterus is painful, but it's an awesome method of birth control. Getting the implant in does not hurt. And then I talk through what it's actually like to get the implant put in. So the way that I talk about it is I have you lie down on the table here in the office and you put your arm up like this, and then I'm going to feel and measure and mark with a pen and then clean off with a special soap where I'm going to put it in. And I inject some numbing medicine, and then I say the injection of the numbing medicine just with a small needle just under the skin is the only part of this that could hurt, and it's like a burning sensation. And most girls say if 10's the worst pain ever, that the injection of the numbing medicine is like a 0 to 2 out of 10. So making it really concrete for them. And the reason we put the numbing medicine in is so when the implant goes in, it doesn't hurt. It could just feel like pulling or tugging. And it's such a small mark that it leaves after we put the implant in that I just put a Band-Aid on and then wrap up the arm with a special wrap that helps reduce the bruising and swelling. And that's how I describe it to every patient. And I would say the combination of that description, even though they don't totally believe me until it's actually put in, and using the visual aids that I have really help decrease their anxiety about it. Some patients have thought they're going to get a giant metal rod put in their arm, which I don't know where they're getting that idea. But I'd like to show one of the visual aids that I use to talk about these methods. And you can get this from Merck and from the rep. And if you want to get in contact with that person, I can let you know. So I don't know if you can see this little matchstick size implant here. It's actually made of the same material that the implant is made of, so I always make a point to bend it. I've even gone so far as punching it on the table because patients are always worried this is going to break in their arm, so I show them how flexible it is. And one great thing about this, if the patients haven't already felt what it feels like in the arm, is they can palpate, and there's an implant in this fake arm here. So I have one of these in every exam room, and this has been my most favorite and most helpful visual aid. And I didn't bring it up when I was talking about the IUDs, but I'd like to show some of the visual aids that I use for the IUDs. I have one of these in every room. This is also really helpful just to talk about anatomy with patients. And it shows where the IUD is situated inside the uterus. Patients are worried that it's somewhere in their vagina and it's going to be something that's going to mess up their sex life by their sexual partner feeling it. So I always show them. And the display that comes from the, I think it's Bayer that makes these, comes with little IUDs here. And then they also have these little clips that you can wear on your white coat or whatever. And you can just show them physically, okay, this is where it sits in the uterus. The cervix is down here. The cervix is closed. It's keeping it in place. And then I have them feel the strings and say, this is the only thing that's in your vagina, and I cut them long enough so they just curve up behind the cervix there. And I have them touch them and feel them, and I think if you're doing a lot of contraceptive counseling in your work, it is so important to have these things to make it more concrete. I also have these little fake uteruses that aren't as cool as this demo board, but you can get these from the IUD folks as well. So those are the visual aids that I use for that. The other thing that I do with every patient is I provide them with a discharge form that has the most important information about the method that they've selected that they can take home. It also has my clinic phone number on it, and that covers information that I also want them to tell back to me before they leave. I also have them sign an informed consent form for IUD insertion and removal and Nexplanon insertion and removal. And again, just that repetition and kind of reiterating the same thing over and over and having them tell it back to me. I'm always surprised at how little they remember, especially about the main side effects. So I really want to make sure that we're being super clear about methods that will change their periods. So you can see the high points that I like for them to tell back to me during that teach back method. Something that's not set in stone or recommended necessarily is to have a follow-up visit after the implementation of these methods. But after I start any new birth control method, I like to see the adolescent back within 1 to 3 months, just depending on what their situation is. Especially with the pill, this is something that I learned in working with adolescents that I think I would also apply to the adult population. It's really hard to take the pill every day at the same time, and adolescents have used the pill in very creative ways that just based on misunderstanding. So I like to bring them back after implementing any method just to see if they have any problems. We've also seen with adolescents, especially after implementing or starting the Nexplanon, that because of the potentially bothersome bleeding patterns that can result, having them come back and talk about it and just reassuring and reassuring and reassuring can really help support them to keep it in if it's something they're wanting to continue to use, but just need that extra info and support. So again, these are the key principles that I use to kind of structure the presentation, and that's straight from that CDC contraceptive counseling document. This is a summary of the main points. We talked about how long-acting reversible contraception, the implant and IUDs, are safe and effective for adolescents and women who have never had babies before, nulliparous women. We talked about those CDC key principles, and then we talked about the strategies and the resources with an emphasis on the tiered counseling, which is mentioning the most effective methods first before jumping into the other method discussion. And again, all the slides that had the Physicians for Reproductive Health logo on them were taken from this presentation that's linked up there about the LARC methods And they have a lot of other really great resources that are free to check out. And then I have included a lot of different references here, including the ACOG documents that I used to address the points that Dr. Mason had wanted me to talk about. So definitely we're checking out those resources, and I am really happy to answer any questions or go into more detail about any of those points.
Dr. Mason, while we're waiting for people to ask questions, do you want to give a little bit of a sort of a plug for your PEDx series? After you unmute yourself.
Yeah, it's like you must be muted.
And we have a question while folks are trying to figure that out. One of the questions that we have from the chat is, are LARCs safe for smokers?
Yeah, that's a great question. So smokers that are under the age of 35 can use any of the methods as long as they don't have any other conditions that prohibit the use of estrogen or progesterone. The concern about using combined hormonal contraception for smokers is applicable only to women that have comorbidities or are over 35. And all of the LARC methods are safe for smokers of all ages that don't have comorbidities because they're either progesterone only, or in the case of the copper IUD, they're non-hormonal. Is PEDx a plan TEDx? That's my guess, but yes. I'm just here to present this topic. So. I will say that, and I can read off what Dr. Mason wrote. I will say that if you are referring patients in to see me or another provider at a clinic for LARC implementation, if you don't have that at where you practice, it's really great to offer them to start on a bridging method of contraception. Sometimes there are prior authorizations with insurance, or there are other reasons why a patient wouldn't be able to come in right away after you refer them. So it's always great to offer them to start on a method that you do provide in your clinic while you're waiting for them to get their appointment for a LARC if that's what they've decided on. So it looks like Dr. Mason maybe can't speak. So I will share what she wrote. She said the goal of the PEDx is to improve education for practitioners and to also hopefully enable us to better care for more difficult issues, opening up more appointments with specialists for those who need to be seen. And the PEDx is Pediatric Education Dissemination or Discussion. And I will also say that at the Young Women's Clinic, we have same-day, next-day appointments. I have a lot of availability still, and with that kind of flexible schedule, I also am able to spend a lot of time doing this kind of counseling with adolescents. And oftentimes I see, even if they've had contraceptive counseling before, it's really helpful to go over it all again, just because it's kind of intimidating to go through this new information. Is there a time for low-dose OCPs? Yeah, I think that if an adolescent is choosing OCPs as the method that they want to use, I know that one of the nurse practitioners that I work with does a really good job of like following an algorithm about the patient's weight. I mean, if you have a very small patient, I don't have like a BMI cutoff that I would use, and you're worried that putting them on like a 35 microgram pill is going to be too intense for them, that would be an option. If someone has used OCPs in the past, I always ask them, what OCPs have you taken before? What did you like about them? What did you not like about them? If they know what pill they feel good on, I would just say, and that's what they want to use, I would just say, let's try that again. The risk with doing a lower dose OCP is that you could increase the risk of breakthrough bleeding. So what I've seen Dr. Sakari do, the pediatric and adolescent gynecologist that works at UNM, and what I do is we usually start them on Sprintec, to be honest, just one of the most kind of basic, straightforward, I think it's a 35 microgram estradiol pill. But certainly if someone has done well on low-dose OCPs in the past, or they've had a side effect on like a kind of more moderate dose OCP, starting out that way is definitely an option, and I've done that before. My clinic is I don't know if I can roll. Can you go to that second slide that has the tiniest map in the world on it? The Young Women's Clinic is located by the airport in Albuquerque, and so Yale and Gibson, and it's in the same building as the Center for Reproductive Health. Yeah. Oops. There it is. And so you can see that teeny tiny map there that we're on the other side of Yale from the Waffle House. That's what we use as our kind of, not that we promote people going to the Waffle House before or after their appointment, but that's where we are. Yeah. Any other questions? You are welcome.
It looks like we have comments coming in, so we will wait.
Mm-hmm. You are so welcome. And anyone can contact me. I didn't make a slide with my email on it, but it's jarobinson@unmmg.org. You can also call that number at the clinic and ask for me, and I can call you back if you have any questions. Again, I also see some patients at school-based health centers offsite, so I'm not always there, but we do have excellent nursing staff, and then there's always a provider in that physical location, often family planning specialists from the OBGYN or family practice divisions at UNM. So we can definitely serve as a resource to support you in doing this in your practice.
You can also contact us. The slide at the end has the contact information for the folks at Envision, so we can direct you if need be. If you forget all those other emails.
Yeah. Well, thank you so much for inviting me to do this talk, and please feel free to ask me if you have any other questions.
All right, we will see you next time. Keep your eyes on your email for the next session in the PEDx talks. And we certainly have other options at Envision New Mexico, especially around adolescents. If you're interested, we have a Wednesday morning clinic, 8 to 9 every Wednesday morning that's specifically focused on adolescents, and Jen's been a frequent contributor to those sessions. So we hope to see you guys soon.